I wanted to dig up dinosaurs and turn them into robots and have them fight. But that's now I do this. So guys, thank you for today. It's an honor and a pleasure to go after the excellent talks of Justin and Chris, both very educational in a myriad of ways. It is not lost on me that I'm the only thing standing between you and a little break before afternoon activities. So I'm going to get the ball rolling. Um, Today, I'm going to present an outpatient management to osteoporosis management. Oop, if my slides will cooperate. There we go. I have no conflict of interest. Nobody's paying me money. My goal is basically, I do not proclaim to be an expert in anything, but my big goal here is to give you a framework and a little bit more of a extensive algorithm to go by when you're seeing patients for presumed osteoporosis or known osteoporosis and manage them in your outpatient clinics. With that goal in mind, we're going to define osteoporosis, go through its population burden, give you the recommendations for screening and for not only prevention but also treatment, and just different kinds of things to keep in mind treating osteoporosis, especially with our first line medications. So, what is osteoporosis? Basically, it's a systematic skeletal disorder showing increased weakening of your bones. The cortical bone, especially, gets breaks down to the point of being very easy to fracture. That's kind of like a general framework to think about it, but from a clinical standpoint, what is osteoporosis? There's both a radiographic and a clinical definition. The radiographic definition being a bone mineral density of the lumbar spine or hip that's at least 2.5 standard deviations below the mean. You'll see that as that typical T-score that I'll get into more of, at least negative 2.5 or less. But there can also be a clinical definition that is notwithstanding to even needing that T-score, which is the presence of fragility fracture, meaning a fall from like a standing height or less that results in fracture, in the absence of any known other metabolic bone disease, regardless of what their bone mineral density is. So the incidence of osteoporosis in the American population, about 10.2 million people have osteoporosis and 43.4 million people have osteopenia, which is kind of that weakening of the bone as we think of on the way to osteoporosis. 1 out of 2 postmenopausal women will have osteoporosis related to fracture. And of the 450,000 hip fractures that occur every year in this country, 50% will never regain their functional capacity. 25% end up in nursing homes. And the most morbid statistic to me is another 20 to 25% of people die from complications associated to the hip fracture, not necessarily the fracture itself, but just kind of the prolonged hospital stay, the prolonged complications from the lack of mobility, ambulation, other health concerns that come from the hip fracture. This is no poll, just if you can put in the chat, what percentage do you think of women from the ages of 65 to 79 actually undergo then osteoporosis screening, given that we know now what the disease burden. Oh, thanks, man. Well, you're always doing things for me behind the scenes. I appreciate you. You can see my screen, so I don't know why I'm doing this. Give you a second.
Are you able to see the answers for the poll?
I cannot.
It sounds like an even split between B and C, a couple with D.
Pretty good. Answer is 26%. So only of a quarter of this vulnerable population is actually getting screening, let alone prevention or treatment that doesn't take into account for that. Um, so that's all to say we could be doing better. This is a case I like to use to kind of orient ourselves as we go through. I want us to be asking ourselves questions that we're going to be answering about who we're screening, why we're screening, who we're treating. So, in the spirit of that, we have Miss O, who is a 55-year-old woman presenting to establish care at your clinic, maybe at your next wellness visit. She has a past medical history of hypertension, GERD, and hypothyroidism. You ask her about her family history. She says that she has a mother with osteoporosis who had recently died due to complication in a nursing home from complications of hip fracture. And she is worried about her risks and wonders if there's a way to determine if she has osteoporosis. So we ask the question, we give the answer. Who do we screen? Well, the current guidelines are for any woman postmenopausal above the age of 65, screen everyone regardless of risk factors. For postmenopausal women between the ages of 50 and 64, by USPSTF guidelines, we're going to use something called a FRAX risk calculator. And then we'll screen anybody who has a 10-year risk that is at least 9.3%. And then a more interesting thing for men, who I would say is if we are under treating women, we're definitely under treating, or under screening women, we're definitely under screening men. Um, there's insufficient data for the USPSTF guidelines for men in general, but other groups, including the American Academy of Physicians and the National Osteoporosis Foundation, do say to screen men all above the age of 70 and any men between the ages of 50 and 69 who have at least one risk factor for osteoporosis. And don't worry, we haven't gone into these terms yet. I'm going into everything. Risk factors, FRAX calculator, everything. FRAX calculator. So this is going to be a tool we can use to estimate the 10-year probability of hip fracture and major osteoporotic fractures. Think of it as like an ASCVD score for osteoporotic fractures. It incorporates clinical risk factors for calculation, as you can see here, not only the patient's sex, age, BMI, but whether they had previous fractures, do they have a family history of fractures, are they a current smoker? Importantly, glucocorticoid risk is a risk factor for osteoporosis, but specifically, they define that as greater than or equal to 5 milligrams of prednisone daily for at least 3 months or longer in the past year. And importantly, on that note, that glucocorticoid risk does not have to be 3 months consecutive use. It's just 3 months in total over the course of the year in total. Very important for your patients with like gout, rheumatoid arthritis, COPD, where they can have frequent exacerbations. Secondary causes of osteoporosis, which we'll get into, alcohol use more than 3 drinks a day, and the last part is going to be our the femoral neck bone mineral density, which we'll get into more on when we talk about what screening modality we actually use. So secondary osteoporosis causes. About 30% of postmenopausal women can be at an even higher, The incidence of secondary causes of osteoporosis in postmenopausal women is 30%. I'll have one of these at least risk factors. It can be even higher in men and premenopausal women with osteoporosis. These secondary causes of osteoporosis include, but are not limited to, type 1 diabetes, osteogenesis imperfecta, long-standing hyperthyroidism, hypogonadism, premature menopause, any woman undergoing menopause under the age of 45, chronic malnutrition conditions like inflammatory or malabsorption conditions. Think your inflammatory bowel disease, your celiac disease, and any kind of chronic liver condition. Price calculator is very useful. I do advise using it for your wellness visits for at least women under the age of 65. It does have its limitations, though. Those limitations being that, like many of our historical calculators, and I would argue even ones that we use today, um, only four ethnicities were used accounted for in the U.S. calculator. You won't see in the current calculator the option to put in ethnicity, but still that data was kind of used to kind of make the initial equations for the risk calculator. Those four ethnicities that were studied: white, black, Asian, Hispanic. Not only is this like bring into the conversation like social equity and bias, but also like just logistic questions. Like, I have no idea what the heck, if you give me one option, what the heck I am supposed to put in there as a Hispanic white guy. But be that as it may, men are also underrepresented within the data set of the calculator. And because of those specific parameters, you may underestimate risk for fragility fracture in people who have not had a previous hip fracture, because that's one of the options there. Or if the lumbar spine is weak, but the femoral neck looks okay on our screening modalities. So, useful tool, not a perfect tool, is my main point there. So, big point. How do we screen for osteoporosis? We can use our mainstay is the DEXA scan. Measures the axial bone density at the hip, the femoral neck, and your lumbar spine. I'm going to stop talking with my hands in front of my face. Um, the limitations of the DEXA scan, though, are patients above 300 pounds can have difficulty getting access to the DEXA scanner. As you can see, it kind of has that arm that kind of goes over. Report inaccuracies can happen, so always check your report for to outline where they measured. Don't just go off of, oh, the T-score was XYZ, or was this number. See where that measure was coming from. And try to use this is the important thing for your clinical practice. Try to use the same machine over and over again. The machine is calibrated against itself. If I'm starting to send people to like the DEXA scanner at Fred Hutch, I try to make a point of go back to, we're going to send you back to the Fred Hutch scanner over and over again, because there can be those discrepancies in measurements between the individual scanners. So you want to have some consistency on the scanner you're using. Interpreting the T-scores that you're going to get from the DEXA scan, like I mentioned, osteoporosis is any T-score that is less than negative 2.5. Osteopenia, the weakening of the bone, is negative 2.5 to negative 1. So that's a higher score. We all love our negative numbers from algebra. And then a normal T-score is anything greater than negative 1. T-scores versus Z-scores. So anybody who is postmenopausal woman or a man above the age of 50, the T-score is validated to make these kind of claims and clinical decisions. For everyone else, you can use something called a Z-score. Now, what a Z-score is, it compares age-matched, sex-matched, and race-matched norms. And any score above negative 2 then is considered normal. How often should we be screening people? Well, if you have a normal T-score, you can repeat the DEXA in 10 to 15 years. If the patient has mild osteopenia, again, 10 to 15 years. In that moderate, like osteopenia, like 1.5 to 1.99, repeat every 5 years. And then this is where the more nuance comes in. So if you have advanced osteopenia, negative 2 to negative 2.5, repeat that DEXA every 1 to 2 years, or in patients who have risk factors for accelerated bone loss. We'll get into that. A lot of the same kind of factors from that FRAX score calculation. And of course, as mentioned, if you have osteoporosis above the negative 2.5, repeat DEXA after 1 to 2 years, but also alongside this, work up the osteoporosis, treat the osteoporosis. Which is, I know you guys know that, you're all doctors, but the risk factors for accelerated bone loss from the previous slide: advancing age, previous fracture, The only things I can think of on here that aren't accounted for explicitly in the FRAX calculator, low body weight, specifically like rheumatoid arthritis, and then the secondary osteoporotic risk factors that we had mentioned in secondary osteoporosis. What kind of additional workup you need if you're having a new diagnosis of osteoporosis in a patient? You want a CMP, you want to check their kidney function, you want to check their liver function, secondary causes of osteoporosis. You want to check a CBC, make sure you don't have any risk factors for malignancy, myeloma, things like that. TSH, you're checking for hyperthyroidism. In men, you're checking the testosterone level because hypogonadism is a risk factor. And then more direct bone-related issues, so PTH, hyperparathyroidism, phosphorus, is there signs of elevation like bone breakdown? And then the two big ones that you want to do because they're going to guide your next steps in management. You want to check their 25 vitamin D because it's often very low, especially in places like Seattle where we don't get a lot of sunlight. Easy to correct, and it's important to correct because your next steps of management, including the bisphosphonates, which we're going to talk about, are going to have their effectiveness directly related to, correlated, I should say, to how good you are at correcting their vitamin D. Meaning, lower vitamin D is associated with a lower response to bisphosphonate. And you want to correct the vitamin D to a goal of at least 30 to 50 to make sure that you set them up for a good place to have response to your treatment. Calcium is also important because, again, if you're thinking about starting bisphosphonate, which spoilers is the first line treatment, they risk having hypocalcemia from starting that medication. So you want to make sure that we get them topped off and get that calcium into a good space where you're not at threat for hypocalcemia in response to bisphosphonate. Who do we treat in general? We're treating everybody with osteoporosis. We're going to be treating everybody with a FRAX calculated risk of greater than 20% for hip fracture or 3% for, 20% for general major osteoporotic fracture or 3% for hip fracture. And this is a more nuanced take, but consider treatment as prevention for anybody who does not meet those specific FRAX standards, but maybe on high dose steroids or have a strong family history of fracture, have other risk factors for frequent falls that we can't correct in other methods. It's our job as a science. It's also an art. It's okay I'm trying to give guidelines to guide you, and then we'll develop clinical gestalt together. Moving on, what lifestyle modifications then are we going to do to help us treat osteoporosis? Well, per the National Osteoporosis Foundation, interestingly, the USPSTF does not have a recommendation. They say insufficient data for calcium and vitamin D to prevent fractures, but in general, women under the age of 50 should be getting at least 1 gram of daily calcium and 400 to 800 IUs of daily vitamin D. And women above the age of 51, 1,200 grams of calcium and 800 to 1,000 IU of daily vitamin D. If you're making your ABS and you want to have a one size fits all, it's okay to put 1,200 milligrams of calcium and about 800 IU of vitamin D. Nuance it, but I know the value of having a boilerplate ABS. You also want to combine these lifestyle recommendations with weight training and balance exercises. Always limiting alcohol, always trying to help your patients quit smoking for multiple reasons, of course. And then you can do, if you have patients with really bad risk of falls, PTOT. We're lucky enough to have the fall clinic at Harborview, which does a great job of not only having a falls assessment, but also PT combined in those visits. So we have resources which we can utilize. as UW providers. So let's get into first line treatment. Bisphosphonates. They're anti-resorptive agents, meaning that they inhibit the osteoclast function for bone resorption. Uh, Remembering step one, osteoblasts lay down the bone, osteoclasts eat the bone. So this is going to affect those osteoclasts. Bisphosphonates are both available in IV and PO formulations. And remember, repeat the calcium, replete the vitamin D before starting these medications. Those medications being are good phenyldronate, oral form of bisphosphonate. We have Boniva, brandronate. Never used it personally, but it's available in uh, either a monthly tab or an IV formulation every 3 months. Risedronate, which is a daily pill, or again, can do weekly dosing or monthly dosing. And then Zelendronate, which is an IV formulation of bisphosphonate. And on the bottom, I won't get into the minutia, but all of these have proven evidence of reducing vertebral hip osteoporotic fractures. Why they're first line. Contraindications to bisphosphonate therapy. For the PO agents, this is a medication with a high degree of needing patient education and needing to be mindful when giving this medication. So, patient has to be upright for 30 minutes after administration. They cannot have any esophageal disorders like strictures, Barrett's esophagus, any kind of complication of the esophagus. Why those two things? High degree of pill esophagitis with bisphosphonates. You don't want to be causing harm to the esophagus from these medications. And this is just a general thing for all bisphosphonates. Renal insufficiency is a contraindication. You cannot give it to patients with a GFR lower than 30 to 35. That brings us into the IV bisphosphonates, which the only contraindication is that renal function. Sometimes you'll see people be starting on the IV form of bisphosphonates because they just can't tolerate those the PO formulations. That being said, this is another one that if you want to steal for an AVS, be my guest. Things that you should counsel your patient on when you're starting bisphosphonates include making sure they take on an empty stomach. They should be taking it with at least a glass of water, but no juice, no coffee. And something that is nuanced because anybody who's on bisphosphonate is probably going to be taking vitamin D, probably be taking their calcium too. They should not be taking their bisphosphonate with even their calcium or vitamin D supplements. They need to space that out by at least like an hour and a half after taking the bisphosphonate medication. And as mentioned, they need to remain upright, either sitting or standing for 30 minutes after the administration. So there's a lot of things to keep in mind when you're starting somebody on alendronate or other PO bisphosphonates. Counseling is super important because not only do you have the side effects of the pill esophagitis, but you want to set them up for success. You want the bisphosphonate to have efficacy. And if the absorption is inhibited by these factors, you're not going to be doing the best by your patient in treating their osteoporosis. Other side effects to consider with osteoporosis, I'll say you've probably seen these before again with step studying. They're pretty rare. First being osteoporosis of the jaw. Usually you'll see this in high dose bisphosphonates used for people having osteoporosis secondary to malignancy. In typical osteoporosis, only at a rate of like 1 in 10,000 to 100,000 patients a year. Of course, though, because there's a risk of this osteonecrosis, important to have good dental follow-up, important for their dentists to know that they're on bisphosphonates before doing things like a root canal dental surgeries. The other risks that you have is atypical femur fractures. Remember, the reason that we have those osteoclasts is because remodeling of the bone, both laying down and absorption, is important for strength and integrity of bone. So interfering with that can, in rare cases, set you up for atypical fractures. So how will that fracture manifest? You'll see your patient, they'll complain of groin or thigh pain for several months, and that is the ongoing practice going on in the cortical bone preceding the fracture. So that's all to say, if one of your patients who are on bisphosphonate medications come to you with this groin or thigh pain, very low threshold, just get an X-ray. Uh, because you want to be on the lookout for these fractures, rare though they are. Monitoring patients after their osteoporosis diagnosis. You want to get a DEXA scan every 2 years, as mentioned. You'll see in literature, some providers will do monitoring of markers of bone turnover, these being urinary N telopeptide or serum carboxy-terminal collagen cross-links. To be honest, I'd never seen that until I started doing research for this presentation, but they exist. But there's no like guideline driven recommendation for monitoring of these markers of bone turnover. There is some kind of evidence that, hey, maybe they're useful for people with malabsorption, IBD, what have you, or in people who have suspicion of non-compliance to medication. And again, always, like I mentioned with the atypical femur fractures, be on the lookout for any signs of fracture. Low threshold to get x-rays in your patients. How long should a patient be on bisphosphonate? Well, per the FLEX trial, they showed non-inferiority between being on a bisphosphonate for 5 to 10 years. So you can consider a drug holiday for any patient on alendronate for their 5 years who has a low risk of fracture, or any patient who's on zolendronate for 3 years, again with a low risk of fracture. I say low risk of fracture, so who has a high risk of fracture? Well, any patient with a prior compression or hip fracture, any patient undergoing ongoing glucocorticoid therapy, and any patient with a repeat DEXA with a T-score below negative 2.5, despite being on optimal bisphosphonate therapy. What is the total time a patient should be on bisphosphonates in general? No safety data for bisphosphonate use greater than 10 years. That's the maximum recommended oral treatment duration. And if you're hitting that point and you're still wanting to have further management of their osteoporosis, that's where we're at least myself as a primary care provider, I'm asking for help. I have my friends over at the Roosevelt Bone Mineral Density Clinic for sending them and getting counseling on other treatments like denosumab and teriparatide. I think I have something in the chat. Sorry, Chris.
That was a while back.
Okay, sorry. Thanks, guys. So that's bisphosphonates. I'm going to briefly, just being mindful of time, go into these other options, which I'm saying that I'm not typically prescribing, but just to know what the options are. We have hormone replacement therapy. It's an off-label use, but because low estrogen state, low hormone state is associated with osteoporosis, intuitively, repletion of the hormone would guard against osteoporotic fractures. However, numerous contraindications, cardiovascular disease, blood clots, breast cancer, and you can't use hormone replacement therapy for more than 10 years after menopause. You also have raloxifene, which is that mixed estrogen and agonist, agonist at the bone, which is why it's helpful for osteoporosis, antagonist at the breast tissue, why it's useful as an agent against breast cancer. It's indicated in premenopausal women who cannot tolerate bisphosphonates, postmenopausal women at a high risk of breast cancer. It's also useful for contraindications again are VTE. Interestingly, you should be conscientious of cardiovascular risk factors, but unlike HRT, it's not an absolute contraindication. There's conflicting studies, but Then we have our teriparatide, the parathyroid hormone analog, not a first-line therapy, used in patients with severe osteoporosis with high risk of fracture, and anybody who has a contraindication. And
Okay.
IV second line therapy. This is important to point out though, because an absolute contraindication of the bisphosphonates is that kidney functions, and you can use this with a chronic kidney disease, but the risk with denosumab is that as soon as you stop the denosumab, there's an increased risk of fracture after its discontinuation, disproportionate to just the patient has untreated osteoporosis. And then we have romosozumab, which is used in severe osteoporosis. Again, lack of treatment response to bisphosphonates. Can't use it in people with an MI or stroke. Can only use it for 12 months. Again, I know I'm being very brief and quick on these medications. These are the medications where I'm asking for our help from our endocrine colleagues or our rheumatology colleagues, bone mineral density clinic to initiate. The key points I want to make sure you guys take away from this presentation: osteoporosis is both radiographic and a clinical diagnosis. While you do want to get a DEXA scan, patients you establish a clinical diagnosis in, you don't have to wait for the DEXA scan before doing next steps of treatment. If they have a fracture from a standing height, they have osteoporosis. It's Osteoporosis affects a lot of people. It is undertreated, uh, and a lot of people never get screened. Remember that mortality risk of like that 20-25% of people who undergo hip fractures. We want to prevent those hip fractures. Um, while it's not perfect, the FRAX calculator is kind of good to take into account for any of your wellness visits in women under the age of 65, like 50 to 65 at least. Don't be afraid to use the bisphosphonates. I know I've said a lot of caveats for and things to keep in mind for their use, but osteoporosis can cause fractures that threaten a person's life. Bisphosphonates are first line for a reason in preventing those fractures. And there are other meds to try after bisphosphonates. Ask your osteoporosis clinic for help in these next steps. Then I want to get into some questions, but I think I have a couple questions. Cool. We got like, yeah. So we have a 65-year-old woman presents for follow-up, 6-week follow-up after open reduction in internal fixation of femur fracture. In addition to or starting alendronate, bisphosphonate. Well, can they see it if I answer this question? Just as it might pop up the answers quicker.
Sorry, there's a poll currently.
Okay.
I don't know if that answered your question.
But if I answer it on my end, are people going to see it? Just to make the
Uh,
point go away.
oh, if you answer the poll, nobody will see that other than it'll be anonymous in here.
Cool. Awesome. Uh, 40%, I see it. 40% answer C, exactly correct. First, you want to evaluate for secondary causes of osteoporosis, other things that you can be treating, hyperthyroidism, hypogonadism, what have you. Then you can start thinking of your next steps, in concordance, calcium and vitamin D supplementation. And if there's no other secondary causes that would cause starting your bisphosphonates. Excellent. Um, and then second question, it's a little bit more involved, but it's the last question. Cutting to the point, we have a person who, again, is coming in for a femur fracture after trip and fall. has a medical history, including COPD, um, has adequate dairy intake, no family history of bone disease, previous smoker, but quit 5 years ago, has a T score at the femoral neck of negative 2.6, and the lab values are as you see on the screen. And then the patient goes and has their fracture fixed. They have frequent prednisone use throughout the year. What is the most important next step for this patient? Trick here is look at the lab values for a little hint. Even better on this one. Nice, guys. So yes, start vitamin D replacement. Why? No point in starting testosterone therapy. His levels are in the normal range. Don't need to start calcium treatment in a person who has adequate dairy intake and has, borderline normal but normal calcium. And also more importantly, if he has low vitamin D, and fixing the vitamin D will also increase his calcium. You want to increase the calcium or you want to fix the vitamin D to at least 30 before considering starting your alendronate. And don't be afraid of that elevated PTH. The elevated PTH is because the vitamin D is low. Also, an endocrine thing, fix the vitamin D before you start thinking somebody has like primary hyperparathyroidism or something. Anyway, it's my resources. Special thanks to Madeline Pringle, known to the program as Maddie Hollowed from a few years ago, for helping making this presentation. Anybody have any questions?
There's a question in the chat, Andrew.
Nice. Thanks, Laura. I mean, osteoporosis with a history of fragility fracture. I Nothing that I saw like on UpToDate. So the question is an AHD presentation a few weeks ago, osteoporosis with a history of fragility fracture warrants referral to endocrinology. Would you agree that that's a threshold for referral? So again, not an expert. Nothing I saw on UpToDate says that it's an absolute requirement. However, that being said, it's not maybe this is a personal thing, but it's never a bad idea to get uh, for the specialist involved if you have a suspicion that you're going to need your denosumab, teriparatide, other factors. But if they don't have their vitamin D corrected, uh, they're not on bisphosphonate yet, or they haven't trialed bisphosphonate, I start thinking to myself, what is the next provider going to do that is going to be different than what I'm going to start to do? Because if they're going to correct their vitamin D and start the bisphosphonate, maybe it makes more sense for me to do that and then send them over to them if that's failing. That's at least my practice. And also my social anxiety.
Awesome. Thanks so much for all of the presentations today. Um, have a wonderful rest of your Thursdays.